It looks like it's about noon, and this is Ted Kyle of Conscient Health. Just wanted to welcome everyone to this Facebook Live event where we will be talking about obesity, the frustration of trying to get progress in obesity, and a little bit about HAES. So thanks much for joining, and let's get started. As I said, we're going to talk about why progress in reversing obesity trends has been so elusive. And I want to share just a few slides with you, and I'll give you a link at the end where you can download them if you like as a PDF. These are my disclosures, and here are the objectives. We really want to talk about what's blocking progress in reversing obesity trends. We want to discuss the gap between what we know and what we do, and we want to identify ways to close the gap. So these are the trends. These are the latest data through 2016 on adult obesity, that's that upper line, and youth obesity, and you can see that it's a steady upward trend. There's a few bumps along the way, but in 2016, we hit the highest levels both for youth and for adults in obesity. And severe obesity is growing even faster. So why is it? We've been working on this very hard for 3 decades. Why does obesity prevalence keep growing? Well, I'll offer you my bottom line, and that is that bias is the biggest reason why. Bias, when I say bias in this context, is really a selective blindness to facts. People often, when they are working off of bias, adopt a partial perspective. They reject alternate point of views, and that bias can be against a person, a group, or ideas. And 2 kinds of bias really corrupt our response to obesity. One is intellectual bias favoring personal convictions, in this case, intellectual bias about obesity and what causes it, and then weight bias directed at people who are living with obesity. So in terms of how people look at obesity, people typically view obesity as a result of poor choices. The major sort of groups of factors that people might consider are the environment, choices, and genes. And among those, I'd like you to think in your own head which one might contribute to 70% of an individual's risk of having obesity. Most people are on the fence between it being the environment or the personal choices that people make. But in fact, genetic risk accounts for 70% of the likelihood that an individual person will have obesity. Heredity is the dominant role. Environmental factors serve to activate obesity. And then people can choose what they want to do about it. So it really comes in that order. But why do we have more obesity than we used to have? And the answer to that is not a single factor, but actually a perfect storm of environmental triggers. What I would say is your genes set the table for obesity, but the environment is what serves it up. Simplistic explanations are invariably wrong, whether it's that simplistic assumption that it's what someone chooses and what someone does, or whether it's the food, a simplistic, there's too much sugar in the food supply. There are lots of factors that have come to trigger a much higher rate of obesity in the population. Now, that's the bias about obesity itself. Let's talk about bias toward people living with obesity. And that flows from common assumptions about people with obesity, and in particular, the fact that most people assume, even when they're not thinking it consciously, that they can judge a person's health behaviors based upon how they look. In truth, those assumptions can be wildly wrong. An individual can be living at a higher weight and living out very healthy habits, and a person can be at a lower weight and living out some very unhealthy habits. You really cannot assume based upon looking at a person. But because people assume things about people with obesity, that generates demeaning stereotypes of people with obesity being lazy, stupid, undisciplined, and the list just goes on and on. This has been extensively documented in the research. And that bias tends to compromise the quality of care that people receive. They get less empathetic care, less preventive care. They feel berated and disrespected, and obesity is blamed for every symptom. That sets up a vicious cycle that fuels more and more obesity. Obesity leads to a health impact. It causes someone to seek health care. When they seek health care, they often encounter weight bias, which leads them to avoid going back to the doctor. And it also, according to research that's been done looking at this, it also leads to more unhealthy behaviors where people cope with the bias that they encounter with food or other things that aren't helpful. Living with obesity also, for physiologic reasons, makes people sicker, because obesity produces stigma and causes someone to encounter stigma, which is very stressful. It activates certain pathways in the brain that then have an impact on cognition, on physiology, on biochemistry, and ultimately on behavior, thus leading to more obesity. This observation comes from a study by a review by Tamiyama this year, and that summarizes a whole lot of research on this subject. So as a result of these two things, the biases about obesity and the biases toward people with obesity, bias gets in the way of progress with obesity. Stigma leads to denial and inaction on the part of people with obesity. People seek less care, they get poor care, and their health suffers. And it also leads to ineffective policies to address obesity. Let's talk a little bit about explicit versus implicit bias. And this is a study that was published late last year about these two different kinds of bias, about many different things. Now you can see from this chart that bias about sexuality, race, skin tone, age, disability, and weight, in terms of explicit bias, what do we say to ourselves, what do we say we feel, that is down across the board, even weight bias. And speaking specifically about weight bias, what has happened, these are Google Trends data, but what you can see is that a number of social movements have converged to make fat shaming unacceptable. It's just not what polite people do. Unfortunately, implicit bias is growing for weight. In sexuality, in race, in skin tone, it's down. For age and disability, it hasn't increased, but for weight, the implicit bias that people express has actually grown over the last decade. Now, one of the reactions to all of this bias is the reaction of folks who are advocates for health at every size and fat acceptance. The fat acceptance advocates are arguing strongly for reclaiming the word fat and destigmatizing it. This is not a large group of people, according to what I've seen. About 15% in this research that I did actually view fat as merely an objective description, and that would include folks who are actually not in the fat acceptance movement, but rather just saying, you know, I don't see what's wrong with calling somebody fat. Most people view it as being an offensive insult or at the very best neutral. And so you have a couple of example tweets from folks in the fat acceptance movement sort of expressing their point of view about obesity. and the idea of obesity being a disease, which many in the fat acceptance and the health at every size movement reject and ask that it not be referred to as such. The word obesity is actually offensive in that context to folks in the Hayes movement. And so, as a result, the intersection of obesity with Hayes is very thorny. Here you have a fat acceptance influencer written about by the Associated Press describing her concerns about a medical need to lose some weight and fears of being rejected. It's a fraught topic. So, having said that, let's talk about what the policy implications are for bias about obesity. And the common assumption is that obesity, especially around policymakers, is just the result of eating more calories than you burn, a simple question of energy balance. Unfortunately, that's not exactly true. In fact, while rocket science is complicated, obesity is far more complex. And that's because it grows from complex adaptive systems. You push on the systems in one place, and they tend to push back in another and adapt to things that are being done to try and combat obesity. It's a push-pull, very complex system that we don't understand mechanistically. We understand pieces of it, and we keep trying to address it, but it's kind of a trial and error effort in terms of policy efforts to address obesity. Nonetheless, bias drives some of the decisions that affect clinical care, because a common thing that you hear from policymakers is that prevention has to be the primary strategy for dealing with obesity, because there's simply too much obesity to treat. The result of that is we have 5 million children with severe obesity and only 37 clinics that are at all equipped to deal with that severe obesity. For adults with obesity, self-care is often the only option available. That's certainly true for children and their families as well. And when self-care doesn't work, there's a big market out there for weight loss scams. One of the factors that goes into that is that many health plans discourage people from seeking obesity care, but the complications of obesity are fully covered. What anyone who knows something about obesity will tell you is that good evidence-based care utilizes the entire continuum of care. Post-surgical care at the very top, because surgery is not the end of the road for a person, but just one of the tools in the toolbox. So let's talk about progress, movement toward progress against obesity. Why is progress so slow, but yet we do have some progress? Well, in 2013, the AMA declared that obesity is a complex chronic disease. That was a long path that started with the predecessor for CMS called HCFA saying that obesity is not a disease in 1977. Then in 2004, CMS said that obesity is not a disease, and that opened the door for Medicare to cover bariatric surgery. And then in 2013, the AMA said that obesity is a disease. Public views then began to slow shift away from the idea that obesity is merely a personal problem of bad choices. It's a slow shift. That's still a very common thought, but the shift is taking place. And that's because obesity science is bringing better insights and solutions. The hypothalamus, we know, controls fat mass. It's a it's a process of homeostasis, just like the way the brain controls blood sugar. We have more therapies to manage obesity than we used to have, and bariatric surgery has been shown to extend people's lives and put diabetes into remission with a high degree of frequency. So just to kind of summarize, I'd like to say we have opportunities. Better progress will require objectivity to replace bias. We need curiosity about obesity and the people it affects in order to make progress. And we also need to do a better job of providing care for these people. So for more information, you see my social media handles here, and I'll also say that the slides are available at this address, and I'll add that in the comments on this section. And I'd like to check and see if we have any questions. I'm sorry, I wasn't saying anything. I was answering the questions. Actually, I was thinking I needed to type them. Thank you, Leah, for reminding me. What I was going to say is that regarding the DPP, for folks who meet the criteria to enroll in the DPP, it's actually a form of obesity treatment as well as being a form of diabetes prevention. So it's kind of both. And again, sorry. Thanks for letting me know that I was just typing and not talking. Had to remember to talk. Any other questions that people have? Okay, well, I covered fairly quickly. I'm guessing that you heard all of those slides and that outline that I went over. I'd really love to respond to your questions or anything else that you'd like me to address. I know that I have time set aside until 12:30. Eager to hear what's on your mind. Mary, hang on a second. Let me find Mary's question. Mary, along these lines, how would you recommend following? Who else would you recommend following on social media? Well, my golly, I follow a lot of the folks who are registered dietitians who are very prolific out there. One thing that I would recommend if you're interested in what's being published in obesity is the Obesity and Energetics updates that come out weekly. And those really summarize just about all of the headlines and new studies that have been done. It's a whole lot of reading to read all of it, but it's just a page of approaches to it's a page of everything that's been published in the week about obesity that's of any significance. And so it's a really good thing to follow. It's just that if you search for obesity and energetics, you'll come upon it, and you can subscribe. They come out every Friday. I also see a question about the 70% heritability figure being something that surprised people. And I would say that I do hear a lot from people who find that surprising. I get some very smart people who want to tell me, and actually my post today on conscionhealth.org is about heritability and genes and destiny, because a lot of people want to say, never mind your genes, you can be the master of your own destiny. And that's certainly a good sentiment, and it's certainly true up to a point. But if somebody has a very high genetic risk score for obesity, they know that the odds are stacked against them. And when you tell them that all they have to do is work at it and obesity will cease to be a problem for them, that can be a very discouraging message for someone whose lived experience really doesn't line up with that. There's a question here from Monica about applying the Hayes model to the DPP. And I'll have to say that I honestly don't know about that, because it really doesn't conform to the whole idea of weight not being an important consideration for health outcomes. It's the DPP really aims to help people lose about 5% of their baseline weight and maintain that lower weight over time. It's not drastic weight loss that's involved in it, but it's sufficient to have a significant impact on the likelihood of progressing from prediabetes to type 2 diabetes. So I hope that's a good answer, but if you really want to know what Hayes people think about the DPP, I can only offer you speculation. You'd probably be best to get that directly from a Hayes dietitian. I suspect they would be less than enthusiastic about it because of the weight loss that's involved in it. And I see that Mary John follows the Obesity and Energetics updates, and it is fabulous. It's one of the best. I do follow a lot of stuff from Tim Caulfield, Yoni Friedhoff. I follow somebody that I really admire, and that is Dr. Arya Sharma. He's active has both a blog and a presence on social media. Certainly the Obesity Action Coalition has a fabulous community, particularly if you want to understand people who are living with obesity. And then there's just a whole lot of dietitians. A person that I admire a great deal is Michelle Cardell, who's very active on social media, and there's a whole range of other people. Other questions? We've got about 5 minutes left, I think. Ellen, thanks for joining. And I know that you're somebody that I follow closely on social media. People were asking who to follow. And thank you for the reminder about person first language. I was talking with Leah this morning about person first language, which is a convention that goes way, way back to the disability and chronic disease community. And so person first language holds that it's best to identify the disease but not identify the person as being their disease, not calling somebody obese, but rather talking about their condition. Now, obesity is a tough word for a lot of people. It's a tough word for the folks in the health at every size movement. It's a tough word for a lot of the clients. So when talking about obesity, you will not find me using the word obese. You will find me using the word obesity. In the HAES community, for a lot of people, even the word obesity is a problem. Fat acceptance advocates are arguing for reclaiming the word fat. But as you saw from the survey research that I provided, most people in the public are really not comfortable with claiming that word. So what I would say is that it's best to think of the whole person. It's best, I don't know of anyone who advocates for using the word obese, and I've yet to find a situation where you can't gracefully talk about obesity rather than obese people. But I think it's also important to understand where your client is coming from and use the language that they prefer. Really patient-centered, client-centered approach to clinical care is something where you seldom go wrong. Other questions? Ellen, what role does weight stigma have in our own practice? How do you recommend addressing this? I would start by saying that everybody has biases. I have biases. Everyone does. And if you take the implicit bias test, which you can, you will get the score for what your unconscious bias is with regard to weight. And you might find that surprising. The best first step is to be conscious of bias and check your assumptions. Listen to people. What Gary Foster told me, who's a very smart obesity expert, he said, if the subject is obesity or weight management and you're doing more than half of the talking, or if you're doing half of the talking, you're talking too much. So really the best thing to do is to make sure that you're listening as much or more than you're talking when you're dealing with a client. And that way you can be more sure that you are not imposing your beliefs, your assumptions on your client, but rather you are understanding where they're coming from. And Ellen, you're right, that obese is used in a lot of nutrition language, and there are folks who object to person first language because they've always talked about people as being obese. You will find journals that use the language of being obese. Still, even you will find it in the Journal of the American Medical Association, although the American Medical Association Style Guide, which JAMA is governed by, says that person-first language is preferred. What I think about this is that it's a tell. It's a tell that a lot of people have implicit bias where they are thinking about the person as an obese person first rather than a whole person. And I have to say that I have a deep conviction that that's wrong. You don't think of cancer patients as being cancerous. There actually isn't an adjective for cancer that you could use, or a noun form of a cancer patient that you can use. People don't like to be thought of as being their tumor. They want to be thought of as a whole person, and you're right, Ellen, that needs to change. So it looks like we've hit the 12:30 hour. You'll still be able to ask questions and comment after we end the live video, but I want to thank everybody for coming and tell you that I'll be looking at the comments and the questions. If I've missed any, I'll be sure and type some in. I thank you. This is my first ever Facebook Live.